This is Ian Doyle, Board President of the Oregon Board of Pharmacy. We're now coming back from break at 9:31 a.m. We will resume our rulemaking policy discussions with Staff Member Davis. We will be now taking on mainly C5, that's Charlie C5. Staff Member Davis.
Staff Member Davis, this is the annual adopted standards by reference package. I know it's not the most exciting stuff. It's a relatively dry package. I'll try to move through it as quickly as possible and highlight just kind of the more important things that are maybe different from last year. So this is the board's first review of the proposed rule language to update the adopted standards by reference and multiple divisions of OAR 855. OAR 855-102-0040 requires the board to adopt standards and other publications by reference as necessary through administrative rule. All outside standards, statutes, rules, and publications referred to in any rules adopted by the board are by those references made as a part of the rules as fully set forth. Copies are available for inspection in the office of the Board of Pharmacy. So for the United States Code, you'll see every instance of USCs that are mentioned. The newest published currency date is 3/23/2024. The electronic version of the USC is recognized as the official publication of the USC, and thus the dates for USCs are typically quite current. For the Code of Federal Regulations, the newest published currency date for the 16 CFR is 1/1/2023. Did I say that? I'm about to say this wrong. 1/1/2023, and for 21 CFR is 4/1/2023. The electronic CFR is not recognized as the official publication of the CFR. Every year I check it and I hope that they've finally gone to it, but they haven't yet. So we have to rely on the physical published versions for currency dates. That's why the currency date is typically more than 1 year from today's date for the CFRs. Other standards adopted by reference have their own currency date, and that date is reflected in the proposed rules. In addition, you will notice at the end of each section of rule where a standard has been adopted by reference that there is a statement that publications referenced are available for review at the agency. Board staff are standardizing this language in each rule where a standard is adopted by reference as required by our statutes and ORS 183.355. You'll see a couple instances of where we added a new standard by reference, but we forgot to add that statement. So as we're going through this year, we're adding that statement at the end. In addition, this rule package removes outdated terminology related to individuals with intellectual disabilities in OAR 855-0417-50, and I'll point that out when we get there. Today, the board will consider sending the proposed rules to the May 2024 rulemaking hearing to potentially adopt in June and to be effective upon filing. So in definitions, I'm not going to go one by one through these. The USCs have been updated and the CFRs have been updated. I'm going to point out any other standards that are adopted by reference that are not USCs and CFRs. So Staff Member Melvin will be scrolling and I will tell her when to stop. But in this rule, it's all CFRs and UFCs. In paren 36, the official compendium means the United States Pharmacopoeia or USP, the National Formulary NF. And it's just updating which issue of the USPNF is the official current version. And for the Homeopathic Pharmacopoeia of the United States or HPUS, updating it. These are both references that are available online. The next rule is 855-041-1046. This is USC and CFRs only. 855-041-1092. We have CFRs. 855-041-1145. We have CFRs. 855-041-7050. You have CFRs. In paren 3, community-based care facility means a home, facility, or supervised living environment licensed or certified or otherwise recognized by an agency of the state of Oregon, which provides 24-hour care, supervision, and assistance with medication administration. These include, but not limited to, adult foster homes, residential care facilities, assisted living facilities, intermediate care facilities for individuals with intellectual disabilities and inpatient hospice. While creating this rule package for board consideration, agency staff noticed the outdated terminology related to individuals with intellectual disabilities. Rosa's law was signed into federal law in 2010, and it changed all references of mental retardation in federal law to intellectual disability or disabilities. Intermediate care facilities for individuals with intellectual disabilities are Medicaid-funded institutional long-term support and service for people with intellectual disabilities or related conditions. The next rule is 855-043-0545 CFR updates, 855-043-0740 CFR updates, 855-045-0200 has a couple of USP updates. This is these are the USPs that the older USPs that were previously used. And then the next rule has the compliance with the new standards. You see that we're changing the date from 22 to 23. Last year it was published, but it wasn't official. This just changes the official date. It doesn't actually change the document itself that is being referenced. In 855-080-0020, you have USCs being updated. 080-0021 CFR, 022 CFR, 023 CFR, 024 CFR, 026 CFRs, 028 CFRs. It also has in paren 3 the table of exempted products list, and I have downloaded that. The most current version is 1/11/2024. And 080-0031 CFRs, 0065 CFRs, 0070 USCs and CFRs, 0075 USCs and CFRs, 0085 CFRs. Then we go to 855-115-0125. This is a CFR reference. 855-115-0130. This is a CFR reference. 855-120-0005. This is the reference to colleges or schools of pharmacy that are accredited with probation, pre-candidate or candidate status by the Accreditation for Council for Pharmacy Education. I pulled it down from their website on 3/28/2024. 855-135-0001. This is the list of accredited or ACPE accredited providers of CPE and ACCME accredited providers or ACCME recognized state medical societies. I pulled down their list of providers. Next is 855-139-0145. This is CFR updates. 855-139-0350 CFRs. 139-0460 CFRs. 141-0350 CFRs. And that is the end of it. Every instance of when we've adopted an outside standard by reference in our rules. Back to you, President Doyle, for questions.
Board Member Doyle, I'm parched. I need a drink of water now. Dry stuff.
Been waiting all year for this pitch.
Board Member Doyle, we begin conversation with Board Member Patel. Any comments or questions with regard to the package set forth?
No.
Board Member Hibbins,
Nothing to add.
Board Member Barmore,
Rich Farmer, I scoured to verify every number. So thank you for that work. Not jealous of you.
Member Hall,
Overall, no comment.
Member Beeman,
Board Member Beaman, no comment.
Member Doyle, I have no questions. Board Member Chin,
No questions.
Member Joyce.
Dry as a desert. No comments.
So I asked the board, is there a motion to move to send proposed rules OAR 855-006-0005, OAR 855-041-1046, OAR 855-041-1092, OAR 855-041-1145, OAR 855-041-7050, OAR 855-043-0545, OAR 855-043-0740, OAR 855-045-0200, OAR 855-045-0205, OAR 855-080-0020, OAR 855-080-0021, OAR 855-080-0022, OAR 855-080-0023, OAR 855-080-0024, OAR 855-080-0026, OAR 855-080-0028, OAR 855-080-0031, OAR 855-080-0065, OAR 855-080-0070, OAR 855-080-0075, OAR 855-080-0085, OAR 855-115-0125, OAR 855-120-0005, OAR 855-135-0001, OAR 855-139-0145, OAR 855-139-0350, OAR 855-139-0460, OAR 855-141-0350 to the May 22nd, 2024 rulemaking hearing.
Board Member DeBarmore, seconded Board Member Hall.
Motion has been made by Board Member DeBarmore, seconded by Hall. I will now call roll. Board President Doyle, yes.
Board Member Chen, yes.
Remember Beeman, yes. Member DeBarmore, yes. Member Hall, yes.
Member Hemmings, yes.
Joyce, yes.
Board Member Patel, yes.
Motion passes and those will all be sent to rulemaking hearing in May. We now move on to our last package of rules with Staff Member Davis. This is drug compounding package C7 or Charlie 7. I anticipate that we'll be speaking on this topic up until our scheduled lunch break at 12. Depending on circumstances, we may take a short break within that time period of 5 or 10 minutes per se. And it's possible that we may be continuing conversation on this topic after we come back from lunch. We'll see how things go. Board Member Davis, please.
Staff Member Davis. All right.
Staff Member Davis.
That's okay. Discussion C7 for compounding. So today the board is going to continue its first review of the proposed rules for compounding in the new Division 183. As a reminder, as part of the board's strategic plan, agency staff are working to systematically refresh rules and standardize rule development to improve clarity, compliance, and longevity. The strategic plan, and I'm referencing the one before we adopted one the other day, but the one that was in place specifically said to amend rules for drug compounding to ensure consistency with updated USP chapters 795 and 797. So the board utilized a work group to develop and revise these rules. The work group met 5 times in February, April, May, June, and July of 2023. As a reminder, a work group is a public body and is subject to public meetings laws. Work group members represented the interest of persons or entities that are likely to be affected by the rule. There were 3 institutional-based compounders and 3 retail compounders represented on the work group, or community compounders. Work group members provide advice and insight on the specific topic and any proposed rules related to that topic to the board. The work group's role is advisory only. Based upon input from the work group and using the lens of patient safety, agency staff drafted the rules and modifications to the proposed rules. In June 2023, you may not remember, it's been almost a year. So as a reminder, the board didn't have the chance to discuss the proposed rules, but you did send the rules to rulemaking for public comment only. So between the month of June and July 2023, we received a number of public comments. The work group then had one meeting in July 2023, and we discussed some of the public comments, some items, but not all. And then we made further, agency staff made further modifications to the rules. So the work group has not seen the rules as you are reviewing today. There were further modifications made after that July 2023 work group meeting. However, the rules you are reviewing today are pretty much frozen, as I would explain, to what was written in August and what we've been bringing up at each board meeting that we've had a moment to get to this rule package. So you may notice like the adopted standards by reference. I didn't go in and update all of those to show what you just approved. I will. Today is a conversation, right? We want to hear what you guys think. We want to know, like, do you think we got it right? Did we go too strict? Did we go too loose? And then we'll go back and revise these rules. So we're not sending these to rulemaking today. This is very much your initial discussion to kind of give staff direction on where your temperature is at and where we're headed. So the rule language highlighted in yellow on this draft denotes the agency staff proposed amendments that were made between the package going to rulemaking in June 2023 and then the August 2023 board meeting. So you'll see throughout there's kind of yellow highlights. That's just to point out to you like, hey, this is not what you sent to rulemaking. So you may have rulemaking comments that are kind of talking about something different than what you're actually reading in the rule, because we did make changes based on those initial public comments and the work group's feedback in July. And I'll be honest, like the original plan was we're going to come to you in August, we're going to go all the way through these. And we potentially had told the work group in July, we may meet again in September. You know, once the board talks, we'll take a look. We might need some time. We may pull you back together, look at some things again. So that's just kind of just been this very protracted process that we've engaged in here. And so we will still need to do quite a bit of work on these rules, and you'll see them again before you would ever be sending them to rulemaking. So at the August 2023 board meeting, the board discussed proposed amendments needed in Division 6, 41, 43 to align the definitions and outlet types with the amended compounding rules. So we pretty much handled every chapter other than, or every division other than the compounding division in August. At December, the 2023, the board discussed proposed amendments in the new division related to personnel and began discussion on compounding general requirements. Then in February, the board discussed proposed amendments, again in the compounding division, related to flavoring and the role of barcoding, imaging, or gravimetrics. So today we're going to pick up where the board left off. I'm not going back to the beginning. We're going to just pick up where we left off at the last board meeting with the goal of getting all the way through this one time. Okay, and then at the end, if we have time, you can go back and maybe make some additional comments if you had noticed things that are in the rules that are prior to where we're going to pick up discussion today. Again, just as a reminder, these rules apply to the preparation and dispensing of compounded drugs from a drug outlet. These rules do not apply to the preparation and direct administration of compounded drugs by a healthcare provider. And then I'm going to have staff member Melvin pull up the presentation that I gave at the August 2023 board meeting. So we're talking 9 months ago. I gave a presentation to the board on some basics on compounding. I'm not going back through this verbatim. It was a much longer presentation, but I did want to hit a few highlights before we go into some discussions, just to bring to the top of your mind a couple of important distinctions. So in this presentation, you can always go back and look at those on you in the public. It's linked in the minutes to the August 2023 board meeting. You can pull the presentation up. We talked just briefly at the beginning about the New England Compounding Center. That was a compounding pharmacy in Massachusetts. They distributed contaminated steroid injections that caused a nationwide outbreak of fungal meningitis. The outbreak resulted in 753 patients infected and at least 64 patients died. Get this next slide. The cause of the outbreak is likely that the steroid injections were contaminated with a fungus. That fungus is found in soil and plant debris, and the fungus was likely introduced into their compounding facility through contaminated environmental air. And the picture you see is a landfill that was right next to their building. On the next slide, as a result, NECC filed for bankruptcy. They paid out millions of damages to the victims of the outbreak. The company lost its license to operate as a compounding pharmacy, and the outbreak led to changes in our compounding pharmacy regulations at the federal level. Next slide. Many states enacted new regulations for compounding pharmacies as a result. We did an update to ours, and then, we're doing a new update because of the new USPs. On the next slide. So with the NECC, what happened with the NEC highlighted the importance of oversight of compounding pharmacy, the importance of reporting adverse events, because these patients, they were all across the country. I skipped over that slide, but they were all over the country. And so reporting adverse events from patients that were receiving this product was how they were able to track and trace what was going on. At the federal level, the federal government created new regulations. The Drug Quality and Security Act was signed into law in 2013. And Title I of it is called the Compounding Quality Act. It sets forth new requirements for compounding pharmacies, and these requirements are designed to ensure that compounding pharmacies follow strict safety procedures and produce high-quality compounded drugs. There's two terms that you'll hear a lot today, especially for our public members. 503A pharmacies and 503B pharmacies simply refer to the corresponding sections in the Act that govern the regulations for these types of pharmacies. In a nutshell, a 503A pharmacy is a pharmacy that we think of, a traditional compounding pharmacy located here in the state of Oregon. These pharmacies are preparing customized medications for individual patients based on a prescription. They could be located out of state as well, but when we think of them, we think of our local ones. They primarily serve patients with unique needs or those needing personalized dosage forms such as customized creams or capsules. And these pharmacies are subject to our rules for compounding that we're reviewing today in Division 45, what will be 183. On the other hand, a 503B pharmacy operates as an outsourcing facility. Unlike 503As, they engage in large-scale compounding without the need for individual prescriptions. These facilities focus on producing standardized medications in bulk for healthcare providers and hospitals, and their aim is to ensure a reliable supply of compounded medications while maintaining quality and safety standards. These pharmacies are subject to our rules for manufacturers. They're looked at more like a manufacturer doing high volume compounding. Excellent. FDA views all compounded drugs as non-approved drugs. So this means that compounding pharmacies are considered manufacturers of these drugs, and in some cases, they must follow the same manufacturing regulations as traditional pharmaceutical manufacturers, the 503Bs. Pharmacies cannot generally compound drugs on certain lists. So there's the FDA's drug approval list, there's the drug shortage list, there's drug products that have been withdrawn or removed due to market safety issues, drug products that are subject to risk evaluation and mitigation strategies. It's just high level. There's exceptions, of course, to all of these things, but just there's lists of drugs that can't be compounded. And I think this is the next to last slide I was just going to review. So this is kind of a chart that shows like the difference. You have a traditional pharmacy versus an outsourcing facility. 503As register with us, the state. 503Bs register with us as a manufacturer and the federal government through the FDA. 503As are inspected by us and they can be inspected by the FDA. Also 503Bs can. At this time, I'm unaware of a 503B being physically located in our state. They're all out of state that are shipping in unless you know one, and this board member knows of one. 503As do patient-specific compounding, where 503Bs can do non-patient-specific compounding, large-scale compounding. Doesn't have to have a patient name on it. They bulk manufacture and ship into our state. 503As meet those unique needs with personalized dosage forms. 503Bs are really producing standardized medication in bulk primarily for hospitals and other large volume providers. 503As have patient-specific labels. It's going to have the patient's name on the label, whereas a 503B is going to have kind of like repackaging labeling, like this is what's in it, this is the date it was made, this is when it expires, but not a patient name tied to it. 503As are required to comply with USP standards per our rules. 503Bs have to comply with current good manufacturing practices, so CGMPs. They have to report a product list to the FDA twice a year, and they also have to report adverse events to MedWatch because they are manufacturers and treated as manufacturers. It's just some important distinctions to kind of keep in mind because we're going to be talking about both 503As and some 503B type activities today. Finally, the last slide I just wanted to mention was the United States Pharmacopoeia, or USCP, set standards for compounding practices. These standards are designed to ensure safety and quality of compounding drugs. However, some states have enacted regulations that go above and beyond USP standards. Obviously, Massachusetts, where NACC was located, implemented many much more strict than USP standards. California, our neighbor to the south, has quite a few that are more strict than USP. While state regulations for compounding pharmacies vary widely, there are some core components that you see in many states. One is a written quality assurance program because they are kind of doing compound manufacturing light. The state inspections of these facilities and adverse event reporting. So you'll see those kind of key pieces tend to pop up. And that's where I'm going to stop. I'm not going to go back through the whole presentation. You're welcome to review it. There's more in the presentation about some ISMP and technology, some things we've already discussed as a group, and then also some cases with the FDA and with the state board related to compounding we covered at that time. Right. So with that, I'm going to go back over to our rules discussion. We are going to start. Rachel, what was the line number?
596.
596 for those on the phone in this package. Line 596. That's where we left off at the last board meeting. The rule number is 855-183-0200. And we're going to start with paren 5. We discussed paren 4 at the last board meeting, just picking up where we left off. So this first discussion, paren 5, it says it is recommended that verification of CNSPs and CSPs not rely solely on the verification of components after they have been added to the final container. This includes methods such as proxy verification and the syringe pullback method. So the Institute for Safe Medication Practices in 2016 issued sterile compounding guidelines stating proxy methods of verification of ingredients such as the syringe pullback method of verification should never be used. In the 2023 version of their targeted medication safety best practices for hospitals, best practice 11 states that when compounding sterile preparations, perform an independent verification to ensure that the proper ingredients, medications, and diluents are added, including confirmation of the proper amount, volume of each ingredient prior to its addition to the final container. And then in the first bullet, they say specifically eliminate the use of proxy methods of verification for compounded sterile preparations and medications, such as the syringe pullback method, checking a label rather than the active ingredients. Except in an emergency, perform this verification in all locations where compounded sterile preparations are made, including patient care units, and use technology to assist in the verification process, such as machine-readable coding, barcode scanning, RFID of ingredients, gravimetric verification, robotics, IV workflow software to augment manual processes. When technology is in use, it is important that processes are in place to ensure it's maintained the software is updated, and that the technology is always used in a manner that maximizes medication safety features of these systems. So that's all the ISMP recommendation. So when this rule was originally written by agency staff and brought to the work group, we had put proxy verification in the prohibited practices section of the rule. However, the work group provided direction that while eliminating the practice of proxy verification is the right thing to do for patient safety, they preferred that the rule to suggest rather than mandate the elimination of proxy verification. They preferred the suggestion due to operational changes or challenges in eliminating this practice. However, consensus was if must is used in the rule, then the work group signaled that it would need a long implementation timeline, such as 5 years, so that pharmacies could obtain the photo capture software that would be needed to eliminate proxy verification. Right? Those challenges are cost, people, labor, all those things. This is especially concerning, I think, for the work group members that were from smaller hospitals that don't have large, budgets and systems. So the question for the board today is, does the board agree with the work group? Would you like to keep this as a recommendation, a should? Do you want to change it to a must? If you have must, we do strongly recommend implementation dates that are further out. Or do you want to stay silent on this practice and rule? That's also an option. So that's kind of all the options you have today. Do you want to go stricter? Do you want to go less strict? Do you want to just not address this at all? And so I hand it back to you, Board President Doyle, to discuss proxy verification. And if you like this language, what you would like to see happen with this language.
Board Member Doyle, thank you. So discussion on the table for proxy verification and syringe pullback method. We begin conversation with board member heads.
No comment.
Member DeBarmore.
Board Member Barmore. I don't disagree that it is an important safety situation, and but I also understand what it takes to get there and the challenge it could be for small facilities, and those are likely in our rural areas. I think it's good to have it in here, just so there is awareness. And it's not just to the point of calling out having it as non-sterile as well. It's don't mix it all together and then put what you put in there for a non-sterile mix as well. I mean, the risk may not be as high as a sterile mix, but pharmacists should be verifying all the products before they get mixed together, no matter what. Have the ability to see all of the things that were mixed together before it goes to the patient. I am in favor of leaving it in as recommended. As the board continues to grapple with the requirements of technology, do have to consider what happens when technology isn't available because of downtime, because of technology failures. And when we use the word like must, there has to be something also included. What's allowed to happen when it's not available because of unanticipated issues, something's broken, camera doesn't work, whatever it may be. So I just, as we move forward down this road, keep that in mind. Musts go in there has to be a way that we continue providing a service that's critical to a patient. There is a technology failure, but we can still provide access. We can still provide the product in another way.
Member Doyle, thank you. Forgot to mention that Joey is helping us out with timing today. So again, it's set for 3 minutes to keep us on track and help us keep our comments pointed and concise. Board Member Hall, please.
Member Hall, agree that verification method is not safe, and I think for now it should be just recommended because of the cost and time and other issues involved with getting there. My other concern was when technology goes down, when the power goes out or something's not working. We still have to be able to care for our patients. And I've noticed that the more technology we get, the less our staff know what to do in those situations. So like that I worked longer without those technologies that help us. They kind of know, we know what to do because we've worked without them before. And when you have staff that only know how to use these new technologies, when something happens, there's like a gap that I've noticed sometimes. So just need to think about that.
Member Beeman, I am more comfortable with leaving it as a recommendation. Not an ideal situation. However, the more must we put in, that could be recommendations and or previous two programmers have discussed, like when technology fails or systems fail, the more we are limiting patients' access and potentially very critical times. So I'm comfortable with recommendation.
Member Doyle, it's my opinion that manufacture or preparation of CNSPs and CSPs should be moving forward following ISMP recommendations. If recommended is placed in there, it could delay many agencies onboarding of those technologies. Appreciate that they could break down and guidance rule, so to speak, that offers recommendations for standard operating procedures that would need to be put in place if indeed there is some sort of a failure would be warranted. But I'm afraid that if we don't put must in here with a very long moonshot implementation date, that it's just kicking down the can down the road. And I think that we all need to be striving for this more sooner than later. Remember Chin?
Board Member Chin has no additional comments.
Member Joyce?
Board Member Joyce, so, if you look at the evolution of the IV room and admixture, it's gone from, it's over the years, it's become more strict. And it's for patient safety. In regards to the pullback method and the proxy method, there are some cases where medications need to be mixed in an emergency, seizures, right? Need to get mixed like Keppra right away. Pullback method has been used, and it has also been shown that it is by IMSB that is not a safe practice, and I agree with that. And I'm also in line with the thinking that we should start the impetus for stricter standards going forward. So I'm more on the must side than I am on the recommendation side. I understand the potential for costs. And that's why I support maybe a 5 to 8 year period for implementation. A pullback method, it's not, sometimes if when there's an emergency, you have no other choice. And so that's why I think maybe with camera technology for the high risk meds, I would not recommend the pullback method. I would recommend seeing the volume in the syringe prior to admixing. There can be a kind of medium or middle ground when it comes to mixing high risk medications, and a must there with some of the emergency medications. I kind of hesitate a little bit, but right now I'm more on the must side.
Till?
Board Member Patel, before I make any comment on may versus must, I want to draw all board members' attention. We got later from one of the work group member. And it says in the February board meeting, it was my impression that the board members believed that the language in the proposed rules was that appointed compounding work group had recommended, which isn't accurate. In many cases, there were a difference of opinion between what board staff wanted and what the work group wanted. So in some section, there was no work group support and it was left open for board members to review and public comment. With that said, when you say like work group recommended, but work group member did not recommend, I attend that compounding work group, I attend safe practice pharmacy work group, I attend also the CDTM work group, and all the work group members, they are telling board members that we did not recommend it. Now we just continue, just keep ignoring that. Then it just baffled me. As I said earlier, that we should have RAC for the compounding rules, and I'm going to still stand by it. And it's because of that. Like I know this work group member, don't think so she just take this when she write this letters lightly, because she's putting her license risk, her business as risk. It's a lot of risk. And when I'm making this comment, I'm also putting so many things at risk. But I think we should do the RAC for compounding rules. And to be honest with you, that's the unprofessional conduct. Telling board members that work group member recommended when they don't. Is that not unprofessional conduct? And how everyone is just, I hope so everyone read this letter and we're just going to ignore it. Oh, if you don't even, why even we form the work group then? And just write the rules. This is not okay. Now I hope so there is no retaliation against that work group member, because I have zero tolerance for retaliation, discrimination, and bullying. I'm not going to stand by this, that they did not recommend, and I attend these work groups, so I know that. What they recommend, what they don't. And do they have choice, but they don't have choice. This is not okay.
Board Member Doyle speaking. We have three board members had indicated to continue with this section as a recommended, and two board members had indicated, indicating a must. Vote. Member Hemmons? The letter is, there were two letters that were delivered to the board as comments, and they are located in, or I'm double checking.
I'll just help
Yeah.
you really quick.
Okay. There's a file that we have where we receive public comments, and there were two letters that were delivered to us for review in relation to this compounding rules area. That Member Davis.
Senator Davis, if I could just address the allegations that were just made against me. I would like to say that I do my best to represent. I have the notes pulled for each one of these sections. So while some people may feel that I misrepresented, it is not my intention. And I'm happy to pull up the notes and actually look at the minutes, because there are chances, right, where I would say like the work group consensus was, and when you actually look at it, it was a 50-50 split or something like that. And I apologize if I in any way misrepresent the work group. I really look at the work group as a conversation, of dialogue to learn about the practice, how different practices operate, and get that feedback, and then write the rules. So I don't intend to misrepresent any group, and I'm happy to take a look at the minutes that we had from any meeting to look at this. Like specifically for the proxy verification, I have it pulled up, and the group was pretty split. I have must with 5 years, must with 5 years, should, or must with 5 years, should, must with 5 years. And I think we reflected that in the changes that were made, taking from prohibited practice to a recommendation. So I'm happy to do that with each one of these, but it truly is not my intention to misrepresent.
For the additional clarification. Are we ready to the next section that you took? Board Member Hall?
I just have a question. I remember learning a little bit about the RAC versus a work group, but what's the importance of requesting a RAC instead of having a work group?
For Council Hunt?
So we can, provide legal advice on that for you if you would like. But generally, they basically kind of like do the same thing. There's just different like requirements if you do a rack. There's like additional requirements of people that have to be there, the things that have to be laid out. A work group is just a little bit easier together, but either one is, we do the same thing in the end, right? They're both writing the rules, they're both, doing it, or not really writing the rules, they're helping staff write the rules. So, and I've been, and I don't know how many different, I've sat through racks for other boards. And, basically kind of how it happens is, they, bring a draft, staff brings in a draft. And the work group people or rack making people, either one, it all kind of works out the same way. They could just go through them, just like you guys are doing right now. Right, and then the idea is that there's a recommendation made, and the recommendation is brought to the board. It sounds like in this case, there was a split. On these, and so it's hard to bring a recommendation, right, if you don't have a consensus. But in the end, it's the board's decision regardless, right? So all they're doing is recommending it. And so I think it's the hope, right, is that a RAC brings people in from the community that and a work group, right, that are experienced in these areas, and they assist staff with drafting the language, and then the board decides if that's what they want.
Member Hall, thank you. Can I ask for Member Patel why you prefer a RAC?
So there's a difference. So with the RAC, they have to apply to all the public meeting law. There's a gray box. If you see on the roof, they have to apply all the rules. Is the small business affected, not affected, right? It's more in detail. And I don't care if it's a small rule package and if you don't do RAC, but this is this is going to be impacted so many small business, rural, small hospital, Oregon, and everyone. So why didn't we do the rec? If there is not much difference, then why didn't we go to rec and do the proper way? And then you have to minute and the recording and everything is posted. So it's more kind of transparent. I work group, right? And they have to go to all those, like who is that appointee? Who is that work group member? Right? So there's a difference. So why didn't we do that? If that's it.
Member Doyle, I believe that it's generally the governance of the board who determines whether or not it's a work group or advisory committee. So the constitution of the board at the time that it was being promulgated, that this rules package was going to be amended, the board staff was given direction by the board for a work group as opposed to a RAC. Board Member Patel.
I do understand, and that's what I was opposed in the first place, that no, we need a rack for the compounding and for the CDTM. And just to avoid this situation. And this is not the one-off. It's happened with all the three work groups. So that way.
Member Hemmons, did you have your hand up a moment ago?
Board Member Henry, I wanted to ask, who made, kind of answered it. I wonder who decides on whether it's a RAC or a work group. And so you answered that, but my question now is, when was that vote taken? Do we remember?
Board Member Doyle, I do not recall, and we also have had board turnover. For example, Board Member Vipperman's not here any longer, her term expired. So if that piece of data is important for you, then we can try to, at a break, uncover that by looking at the minutes, which are public documents.
Board Member Clements, I guess that I'm just wondering, is there anything that precludes us from actually voting on that again? Considering there seems to be a lot of concerns around this. I'm just asking that question.
Board Member DeBarmore.
Board Member DeBarmore, I was just gonna decide it. At the time, it was the consensus of board to use a work group. And not a RAC. And so I just want to caution in the blame on staff when it was at the consensus of the board. Understanding you not personally agree, but the consensus of the board and the makeup of the board at that time was that a work group would be used to work through. Can that change? Or that's or change. But at that time, and for the other, it also was the makeup of the board at that time and indicated a work group would be utilized. Work groups are public meetings as well, and anyone can attend them. Just for those on the phone, for those around, anyone can attend those as an audience member. And listen in to the conversations to get full transparency. I listened in on several of the work group, and I was not a work group participant, but as a interested citizen and licensee and someone who has to implement, I wanted to understand from the work groups, from SMEs and experienced people in areas that I'm not as familiar with. So when I'm sitting here, I understand from those people, what is the impact that I felt that's my obligation too, as a board member. I want to hear it with my own ears. And I know there were other board members listening as well to hear it with their own ears. So give us credit too. Several of us also heard those meetings. We read the minutes of the meetings. We read the letters that are sent in, the multiple letters over the months and months that have come in. We also have practices and experience. So everybody's doing this.
I saw Board Member Hemmons' hand first, then Staff Member Davis thereafter.
Board Member Hemmons, I'm still trying to, I know the rack is, I've been on rack myself. For other boards, and I'm just, this is just a sense that I get that, trying to frame this in a way that's not, is, what is the, what are the concerns about having a rack? This board,
And the decision for work group versus RAC was made with a slightly different constitution of the board members at the time. And I don't know that we can effectively recall the conversation of choice versus work group or RAC. Board Council Hunt had identified that the effect is the same, that there are certain stipulations that need to be follow if it is a RAC. And with regard to a work group, personally, I'll speak, I found it effective to have this information as an advisory group. Both of them are advisory groups to provide information to board staff. Board staff then bring that consolidated information to us board members, and we're the ones who are able to make a decision if we want to go one way or the other.
Board Member Hemmons, I get the impression that there's a preference for, work groups over racks. That's the impression I get. I may be wrong. I'm just trying to understand the rationale, why that would be. General. But you can move on.
Staff Member Davis, do you allow?
I was just going to answer Board Member Hemmings' question. The board provided direction to convene the work group at the December 2022 board meeting, and it's in the minutes.
Board Member Hemmons, thank you.
Yeah, but
I was getting ready to say the same thing.
Member Patel.
Board Member Patel, no, my intention was not blaming on anyone or anything. But the misrepresentation happened, and then few work group member draw our attention. So as a board member, I cannot just ignore it. And I was there, so I'm just mentioning, yes, and I also attend all the meetings as a good licensee, a good board member. So, and no, I don't feel comfortable bringing out that issue. I really don't feel comfortable. It needs to be addressed. No pleasure.
Board Member Doyle, the next time we have an opportunity to determine whether there's a work group or a RAC, we can have a more robust discussion on the choice between the two. But we currently have the work presented before us today, and we need to move forward with making board recommendations based on the information that we have. Board Member Beeman.
Do we have to do anything officially to have legal advice presented with more education on rec versus work group, or? Just because it seems like it's very unclear to people, and so I think a refresher on that would be helpful for everyone.
We're planning to possibly bring it in June.
Okay, perfect, thank you, especially with new board members coming on soon and everything. I think a refresher would be appreciated.
Member Hemmons.
Board Member Hemmons, so in looking at this drug compounding, why couldn't part of the determination be made? Again, I understand it was done in December 20, and I'm not saying either or, I'm just trying to understand why we wouldn't be able to today. Once again, based on the feedback about this particular section, that maybe it should go to Iraq. I don't understand why that didn't happen. It's part of what you're currently doing right now.
Member Beeman, are you answering that question? Go ahead.
Board Member Beeman, thinking along similar lines with Board Member Hemmings, my thought process was more given the letter we received and given how long this rule package has taken for us to see and how many reiterations of it there have been. And there will be more as we go through it to see and put out the idea out there. And I don't know if it's possible because I don't know that the timeframes or if there's a finite timeframe on a work group, but to once we are more comfortable with language and we take it back to that work group and have the same stakeholders reassess what, or does that have to all be done before the board looks at it? And my main thought process in this is USP has gone into effect since this work group took place. So the changes from USP and the federal changes are in effect, are like, we don't even have a concept as a board of how that transition has been for licensees in terms of cost, in terms of feasibility, in terms of applicability. So we are taking rules with the intent of helping or aligning with that process that has been, we're almost to the 6-month point of, in the right month of enacted date. So like, I think in this particular case, and it's not something we've ever done, getting feedback and perhaps feedback from rulemaking hearing is enough, but again, it gets really uncomfortable to send things forward and not be fully comfortable with how it's actually impacting patients, because USP alone has changes that affect patient access and affect pricing for patients. And there's a lot of effects that have gone into place. How, once we have final language, is that going to make it worse is my concern. And it's just because this has been a very long process for this package. So I think rather than, to me, if starting a rack would be starting from scratch. And we already have had so many people who are experts put in the time via the work group that maybe once we're at a final place, or not final, but at a place we are more comfortable, could receive that feedback before our final look, before we send it to rulemaking. And I don't know, like I said, I don't know. There's so many rules to follow and procedures that I don't know if it, but for me, that makes sense because of the impact that's already happened.
Member Doyle, as Board Member Beeman pointed out, the new USP guidelines have been in effect since November 1st, 2023. I believe that we have a fiduciary obligation to the people of Oregon to educate our rules and how they apply to USP or not. And we have, and we should do that in a timely manner. We have cited for the pharmacists and pharmacies of Oregon that they can follow the older USP or the newer USP. So we're temporarily covered, but I don't think, if you will, continue to kick the can down the road. With regard to previous comments that Staff Member Davis had said, after these rules that we're discussing today are not going to rulemaking hearing in in May, that this package will come back again at a later time. That she had indicated that the previous work group, she had already hinted to them that they were going to be brought back and providing more information on it after it has had board review. Then, so a motion can be made at any time. I would recommend perhaps at the end of the discussion of this package of what the board directs staff to do with the package. And that could be sending it back to the work group or something other. But motions can be made and staff direction being provided by the board. Board member Hemmons.
Thank you for that. Board Member Clements, I was just trying to understand the process and why we couldn't do this versus that. So thank you for that explanation.
Member Joyce.
Board Member Joyce, I just wanted to make a clarifying statement on my comment earlier. I want to recommend for CNSP's elimination of the proxy method. That's not a must for me. For CSPs, however, I do recommend must with certain exceptions for emergency medications.
Thank you. We'll move forward with discussion of the package. I don't have the document in front of me, so I'm not sure which line that will be. Staff Member Davis, you have the floor.
On the phone, it's line 602, paren 6. This says beginning July 1, 2025. Remember, these are frozen. That was written so that it would have a 2-year at least implementation. That date can always be changed and pushed further out. A drug outlet that prepares a CSP from non-sterile ingredients must maintain current compounding pharmacy accreditation through the Pharmacy Compounding Accreditation Board, PCAB, provided by the Accreditation Commission for Healthcare, ACHC, compounding pharmacy accreditation through the National Association of Boards of Pharmacy, NABP, or medication compounding certification through the Joint Commission. The work group, we actually had a work group member that suggested this rule. And then the work group did provide consensus. When I'm looking at it, 1, 2, 3, 4, 5 of the members supported it as written. As the risk of contamination is especially high when performing non-sterile to sterile compounding. Accreditation requires outlets to meet strict requirements and helps ensure that persons performing this type of compounding are doing so safely. So again, the conversation back to you is kind of this may versus must or not at all. What would the board like? What direction would you like staff to work on this role? Back to you, Board President Doyle.
Board Member Doyle, we begin conversation with Board Member. Board Member Hemmons went first, and she chose not to make a comment that time. Would you like to pass at this time?
No, I'm fine. Member DeBarmore, I agree this is a higher risk area of compounding, and
How can you pull that closer?
I think this is an important area to have additional requirements. It's a non-outsourcing, certainly a non-outsourcing pharmacy. So I don't disagree with what is written here. I don't have the strongest feelings as far as the implementation date. Don't understand the steps necessarily it would take a pharmacy to get accredited. So I would have to lean a little bit to stakeholders or others as to if that's a reasonable date.
Member Doyle, I would imagine that the implementation date is going to be adjusted based on the time that it takes for us to continue to move forward. Board Member Hall.
Overhaul, yeah, I agree with must. I just questioned the date, but you answered that.
That would be,
Board Member Beeman, I want to stay silent on accreditation. The option is there. The option has been there. Yeah, I think putting a lot of maze in there and recommendations, it hasn't been the direction of rules the board has done in time here. So I would just prefer to stay silent on accreditation, and we know that it's there, and it is.
Member Doyle, I agree with this being accreditation being a requirement, and there are 3 different options that are provided. So I think that allows latitude for the agency, that being the pharmacy, choosing the path that is best for themselves. Board Member Chin.
Member Chin supports a must.
Board Member Joyce, this is a must. This is in the interest of patient safety, and as you mentioned, it does provide for the outlet some latitude on the options that they have. And this should not present, I don't see this presenting any barriers to having this as a must. Thank you. So,
Board Member Patel, recommendation, not must.
Member Evans.
No, nothing. I don't have an opinion either way.
Board Member Doyle, it appears that there are 4 board members, 5 board members, excuse me, that indicated that this be requirement. Staff Member Davis.
Staff Member Davis will move to paren 7. Oh, sorry, back. Last proposed rule in this section of general requirements. For CNSPs, the compounding area must have a visible line of demarcation to designate the area used for compounding. Other activities may not occur in this area when compounding is occurring. During the second work group meeting, the group reviewed every instance of must and may, the USP 795 and 797. This rule was identified as one that was requested, as it is not a must in 795. It is a requirement in 797 in certain situations. And so the work group had a discussion, and the consensus was to add this for CNSPs, just to have a separate area that couldn't be used for other things when compounding is occurring. Again, always the board's decision to move, to go must, may, stay silent on it. Staying silent on it with me, there isn't a rule because USP also does not address it. The line makes it easy for other personnel to know what the area is that's off limits during compounding. Back to you, Board President Doyle.
Board President Doyle, begin conversation with Board Member Hall.
Member Hall. Would on the side of staying silent if it's not a must. In the USP for like we can use common sense. I would just stay silent and not put anything.
Member Beeman, I would stay silent. It's outlined in that it's I think it's listed as should not in USP. So I think referencing that is it creates less of a less confusion on licensees, and it is there that it should, and so that is the direction that things are going, is it's that the recommendation lies there in that document. Thank you.
Board Member Doyle, wanted to verify with Staff Member Davis, the understanding of the language. Other activities may not occur, which also, it's intended that it could be that they may also occur in that area. Is that correct?
When compounding is not occurring. I'm not sure what you're asking.
My understanding of your explanation of the work group, information was that they wanted the flexibility to have other activities in the area when compounding is occurring.
No, that's what the second sentence says. Other activities may not occur in the area when compounding is occurring. That space could be used for multiple things when compounding is not occurring. But when compounding is occurring, that space would be reserved for compounding only.
And so I think that rather I would think it would be clearer if it were read, other activities must not occur in this area when compounding is occurring. Chin,
Remember, Chen supports staying silent, and continuing with the USP recommendations. And using professional judgment of the part of pharmacists to advocate out to do that.
Joyce,
Board Member Joyce, in regards to CNSPs, I support stating may.
Jill,
Remember, but silent people will use common sense.
Member Higgins,
No, opinion.
Member DeBarmore,
Board Member DeBarmore. I would just recommend removing number 7 because it says the area must be designated. Needs to be clearly marked. We don't have to see that. And it says other activities must not be occurring in the compounding area at the same time as compounding. So USP does clearly say that, so I think we are not including that, and we are adopting USP by reference. It is understood that that is the expectation. I think we need to include, and if we say may not, we would be saying you could. So I say we just remove number 7, and it's understood. You have to clearly identify your compounding area, and other things cannot happen while you're compounding.
Member Doyle, I'm interpreting you to say the board should be silent on this.
Just remove it.
Board Member Doyle, there are 5 board members that have indicated silence on this matter. Turn it to you, Staff Member Davis.
We move to the next rule, 855-183-0205. This is about compounding technology, automated compounding devices. Many states have rules on the proper use of automated compounding devices. I was able to locate over 10 states, at least 20% of states have this. These rules are proposed or were drafted based on a Nevada rule, 639.67017. Look it up. As part of the strategic plan, the primary goal was to articulate the regulatory structure where the accountabilities of pharmacists and the use of technology are aligned to enhance safety, access, service, and efficiency. An outcome condition of the plan was to draft board rules for consideration that clearly delineate the use of new technology and the pharmacist accountabilities in the practice of pharmacy. And you see that today in the set of rules. The language is shown today as a may. As agency staff propose that the board move in the direction of requiring the use of technology such as ACDs or IV workflow management systems. But then the board can determine to make this a must, but the work group had suggested that it would need to have a much longer implementation date again for operationalizing this. So I'll just read it. Paren 1, for the purposes of this rule, an automated compounding device is a device that compounds, measures, and or packages a specified quantity of individual components in a predetermined sequence for sterile preparation. Since the July 2023 rulemaking version that was sent out for comment, agency staff added a definition of an ACD that was missing from the original rules that were sent out for comment. 2, a drug outlet pharmacy, DIPDO, CF, or CHC may use an automated compounding device to A, assist with the compounding of a CSP, or B, produce a final CSP. Again, since that rulemaking version in July 2023, in paren A and B, we've clarified that ACDs only make CSPs, not CNSPs, before the language wasn't specific to CSPs. In paren 3, if a drug outlet pharmacy, DIPDO, CF, or CHC uses an ACD as described in paren 1, the outlet must establish and maintain written policies and procedures, in addition to the policies and procedures established and maintained pursuant to OAR 855-183-0500 that address A, the qualifications and training that a person must have to operate the ACD. We previously used the word use the ACD, changed it to operate. Paren B, the routine maintenance and cleaning required to be performed on the ACD, which at a minimum satisfies the requirements for maintenance and cleaning established by the manufacturer of the ACD. And paren C, the testing required to be performed on the ACD to ensure the ACD is measuring and dispensing the components of the compounded drug product and preparing the final compounded drug product within the tolerances of not more than plus or minus 5%. The word preparing was replaced the word manufacturing. Paren 4, if a drug outlet pharmacy, DIPDO, CF, or CHC uses an ACD to assist with the compounding of a drug product for a parenteral nutrition, the drug outlet pharmacy, DIPDO, CF, or CHC must establish safe maximum limits for each additive that may be used in compounding such a drug product. The outlet must ensure that A, the ACD will not allow compounding the drug product for parenteral nutrition if a maximum limit for an additive will be exceeded until a pharmacist, after consultation with the prescribing practitioner, makes changes or validates the correctness of the prescription or chart order. We use not allow instead of cease. In paren B, if an ACD cannot be programmed to not allow the compounding process described in paren A, large A, the ACD is equipped with an audible alarm or some other mechanism that will alert the pharmacist if a maximum limit for an additive has been exceeded. And paren B, the drug outlet pharmacy, DIPDO, CF, or CHC has written policies and procedures to prevent the continuation of the compounding process once a maximum limit for an additive has been exceeded until a pharmacist, after consultation with the prescribing practitioner, makes changes or validates the correctness of the prescription or chart order. Again, we substituted cease with not allow. And in paren 6, a drug outlet pharmacy, DIPDO, CF, or CHC must make and maintain records that evidence compliance by the outlet with the policies and procedures required by this section. Back to you, Board President Doyle, for discussion. Do you want this rule? Do you not want this rule? As a may, it's just a may, or do you want a must?
Board Member Doyle, I will be talking about 855-183-0205. Board Member Beam.
Member Beeman, I am more comfortable with a may on this. I tend to want to stay silent on things that we're not requiring. However, I like that it outlines if you are choosing to use this technology, then what is required of other technologies that we have in rule. I do get a bit hesitant when we are so specific on technologies, but I think from my perspective, and I'm not knowledgeable about automatic compounding devices, that it seems to be a broad category. And hopefully this won't be too restrictive as pharmacy and technology within pharmacy evolves.
Member Doyle, I support the language as written to be included in rule. My one question or not question, but comment for further contemplation at a later time is, for example, in line 664, when that we're talking about the ACP not allow compounding if the maximum limit of the additive has been exceeded. And so in a stepwise fashion, I'm a little bit confused about how my understanding is it's saying that the ACD will stop or cease working if a maximum limit has been achieved. And then we would go and consult with the prescriber. But it seems as if an amount that had been ordered would have already been reviewed by a pharmacist before the compounding step. But again, it seems as if the order would have been reviewed prior to that. And so that's just a point where I'm pausing to that I, as a practitioner, starting to work with an ACD, maybe or implement. Right now, as a practitioner, not being involved in ACD, marks a little bit cart before the horse, so to speak. However,
You're just cutting out a little bit. Thank you. I think for this conversation is so important for compounding, where I'm struggling a little bit in this row with some cutouts. So if everybody could just pull those a little bit closer, that'd be great. Thank you.
Apologize, staff, board member Chin.
Remember, Jen, I don't think that you said may or must in your, May.
Board member Doyle, I support the language as written, which includes the may.
okay, sorry. Support the language as may, and then in, just out of, something that just crossed in my mind when you brought that up, President Doyle. And, so, yes, the pharmacist looks at the order. Yes, they are aware that it's probably going to exceed something, but I see it as a double check. That happens when I order something that's exceeding and if it comes up with a red flag and I have to say, yes, I know. So I think I see it as a double check. That's all my comment.
Member Joyce.
Board Member Joyce, I support as written, as a may. Your point about the exceeding the limit. I know that in my experience, pharmacists use their professional judgment as far as what is what we call negligible or a insignificant amount within range, so to speak. And that's where the pharmacist uses their professional judgment. But to your point that most, I mean, the data entry happens before it is mixed. So if it does exceed limits, it's the pharmacist's professional judgment of an allowable tolerance tolerated amount beyond that limit. So I see what you mean. And do you think we need to adjust the language there? My question to you.
Board member Doyle, I'm recommending staff look at it and in or combination of helping board members reconcile the information the next time that we review the rule.
Yeah, I mean, I shadow that sentiment because I know there's a certain percentage of allowable or tolerable range, so to speak. Otherwise, I support the language. Thank you.
Member Patel.
Remember Patel, question to board consult, Davis, Nevada, what rule did you say? Would you mind to repeat that rule?
Yes. 639.67017.
I would definitely go with May. Because we have the smaller hospital and if we do they're already struggling with the financially. And if we do this automatic compounding device as a must, They will close down, that means the entire coast have no hospital until they hit the Eugene. So no, it will be just May.
Just laughing because we closed down our hospital in Eugene.
Usually.
Member Hens,
No comment.
member DeBarmore,
Board member DeWarmore, yes, I agree with May as the option as technology advances. I do understand it right now. Today it is only available as fine for sterile compounding, but are we limiting it by stating sterile compounding? It not be beneficial to just call it compounding. We don't have to come back and change rules should technology become available for other mechanisms of compounding. The device may be automated for something in the non-sterile world. It's something to think about. Is just today because it's only available for sterile compounding. Write our rules to fit that. I mean, would we not be okay with similar language for something was used for non-sterile compounding? Thing that are, I think I would just for compounding. So it allows the practice to continue to evolve quicker than we would potentially be able to change rules. You all would be able to change rules.
Paul, I would, okay with me. And, maximum allowable minutes. That's something that would be determined by like policy at the institutions that we're all thinking. That's the limits.
member Doyle, I believe that would be standard operating procedures for whatever protocols, like making a TPN, I think, and there are certain safety limitations that each institution would institute for themselves.
So I would assume that those would be realistic for the majority of patients. But I do see an issue with usually these patients are already approved and it is a double check if an alarm goes off. But as long as it's fine to just, override and say, yes, it's already been, discussed with the physician. As long as the wording is clear, then I think it's fine.
Are there any other board members with additional comments after we've gone around? Seeing none, it seems as there's a preponderance of the board to this rule in place using May language. Staff member Davis, I turn it back to you.
Staff member Davis will move to 855-183-0370 for delivery. This is line 689. For those on the phone. So each drug outlet pharmacy, DIPDO, CF, and CHC must ensure the environmental control, stability, and sterility of all preparations shipped. Therefore, any compounded preparation must be shipped or delivered to a patient or a patient's agent in appropriate temperature controlled delivery containers and stored appropriately according to USP 659 packaging and storage requirements. It has a version date. Information on appropriate storage must be provided to the patient or patient's agent, and then it has our standards adopted by reference language. This language is from the NABP model rules for compounding. Both USP 797 and 795 require compliance with USP 659. However, the language used in the standards is slightly different between the two. This rule would make a consistent standard for both CNSPs and CSPs. I'll hand it back to Board President Doyle, to discuss, do you want this? Do you not want this?
Member Doyle, my opportunity to go first. I support having this rule, in here. Eligible of any news reports where, products have become, deformed, unusable, et cetera, secondary to improper, cooling requirements during transfer with, mass, carriers or transportation departments. To the board member Chin.
The board member Chin would like to hear others only because I don't understand what's already required. It was so fast trying to go through about what's already there and what the real big difference is. So I'll just wait to.
Dr. Davis, I could maybe add a little clarification that might be helpful. So the temperature logs are only required for 795, not 797. And the compounding facility must adhere to standard operating procedures to detect and reduce the risk of temperature excursions within the storage areas within 795, but not in 797. So it's just not addressed the same way between both standards.
Member Joyce.
Board Member Joyce, yeah, I support this as written here in front of me.
Michael Patel.
Board Member Patel, so question, so this one is a new section we are adding, or it was already there? I don't get it.
This is a new section of rule.
Is it addressed in the USP? When it's come from the USP, I see that reference, but did the USP require this rule?
Staff Member Davis, as I said before, both USP 797 and 795 require compliance with USP 659. However, the language used in the standards are slightly different, so this would just make the same standard for whether you're doing a CNSP or CSP.
Something to be already specified. It can be a silent. There, so thank you.
Member Hemmons.
Nothing to add.
Member DeBarmore.
Board Member DeBarmore, I I'm not in favor of adding this just specific for compounded prescriptions. If there's concern with delivery of drugs and things with 659 or language that needs to be rule related to that, I think would apply to more than just drugs. I just have concerns narrowing it to a specific drug type. I don't feel comfortable. I understand the intent and I appreciate the intent. But if it's the board's intent, it needs to be delivery here.
Member Hall.
Hall, I originally was gonna say I support. I hear what Board Member DeBarmore is saying. So I feel like you're more. There's
Member Beaman?
Remember, Beaman, I'm not in favor of this rule, and I don't think we should add it into our rules. We don't require this for other types of delivery, and so it needs to be for all types of delivery, or if we don't address it and it can be referenced in you.
Member Chin?
Member Chin, after hearing conversation, I am in agreement with, staying silent. And if we want to look at all delivery at some point in the future. And then also looking for feedback from the stakeholders when this goes back.
Member Doyle, question for you, Staff Member Davis. A couple of years ago, I recall a presentation from you on refrigeration, and that also included aspects of delivering delivering drugs. I believe there was that it was all delivery of drugs, not just compounded drugs, and I'm asking if I'm misremembering or not.
Staff Member Davis, I know I did one on the refrigeration and when you open the door and how long it takes. So I did that. I don't remember any discussion about delivery of drugs. I do believe there was a presentation at NABP district meeting by the state of Oklahoma on some studies they had done regarding delivery of drugs. And that may be what you were provided with and have seen. But I don't recall that I have done a presentation in my time at the board about drug temperature conditions during delivery.
Thank you. The reason that I'm asking the question is that if indeed my memory was correct, then if at one time it had been discussed, then perhaps it's being queued up to talk about delivery of all drugs sometime in the future. So that not being case as of I'm aware right now, this rule would specifically call out compounded drugs opposed to all drugs. So Staff Member Efimov.
The mic appropriately. So Staff Member Efimov, so it is currently in rule. If you look at 855-41-1036, one says a pharmacy must maintain proper storage of drugs. This includes, but is not limited to, the following. And if you look at C, it says appropriate storage conditions must be provided for, including during transfers between facilities and to patients. And it also talks about published guidelines for USP. So it's included all in 1A through D.
So Board Member Doyle, I interpret that to be that we are requiring appropriate conditions for all medications. So with that additional information, are there other board members who wish to have additional comments? Member Chin?
Member Chin, stay silent, period.
Member Hall?
Board Member Hall, prefer staying silent.
Staff Member Davis?
Staff Member Davis, just to note, the rule that was just cited applies to pharmacies. These compounding rules apply to things that are not just in the pharmacies. So dictos, CHCs are in a different division of rule, do not have a drug storage rule like pharmacies do. So we could also take back your feedback to make sure we add into that division some similar language around making sure that there may be a rule, but I don't know it off the top of my head in terms of delivery by a CHC or dicto.
Board Member Doyle, I would recommend that being noted by staff to look into and that ponderance of recommendations to keep silent, or that there's not support from the board members at this time to include K5518300370. I propose a short 5-minute break and then we will resume again at 11:20 and go until 12 for lunch.